Good afternoon, everyone. Can you all hear me? Happy Friday, Jackie. Okay, wonderful. You guys can all hear me. Whew, okay. So I barely made it. I was at the Florida Professionals in Infection Control conference in Tampa, and my colleague and I were like trying to hurry so that I could get here on time for our group meeting today. So I'm really glad that I made it on time. And I'm excited. So today we're going to be talking about C. diff and tuberculosis. We're going to do our group member spotlight and then go over some of the next week's assignments. So just so that you guys are aware, the Florida Professionals in Infection Control Conference is held every year, and I would really recommend that if you didn't get the opportunity to go this year, to try and go next year. It was really wonderful. We had wonderful speakers. Bill Rotala, Dr. Rotala actually was the first speaker on Wednesday, and his presentation was amazing as always. And so if you do have the opportunity to ever attend that conference, especially for those of us here in Florida, I would really recommend it. It was wonderful. And, it wasn't too pricey. I think it was $345 to attend the conference, which is pretty reasonable for a conference. Okay, so let's go ahead and get started. You guys are able to see the PowerPoints, correct? I know last time I had a little bit of a technical difficulty. Okay, wonderful. Okay, so the agenda for today is we're going to talk about C. diff, we're going to talk about tuberculosis, and then the usual, what we always do. So we're on week 3, right? We're on week 3, and so your assigned chapter readings for this week were pneumonia, TB and other mycobacteria, C. diff and pseudomembranous colitis, and influenza. All of these chapters you will be tested on in the exam. So if you were unable to complete your assigned readings this week, just be sure that you make some time over the weekend or over the next couple of days to catch up and go through these. Chapter 95, so tuberculosis, has a lot of really important information. So much information that I would really need to have like a presentation for TB just on its own in order to be able to cover everything, because there is just an overwhelming amount of information that you do need to know for the exam when relating to TB. Okay, so our presentation for C. diff today is going to be a little bit different than what we usually do. It's going to be a lot more interactive. There's going to be some scenarios, and there's mostly questions. So I really hope that you guys did your readings, because there are a lot of questions and I want to make sure that we're all participating, okay? All right, so let's get started. Okay, so Clostridium difficile is a gram-positive organism. So relating to the peptidoglycan layer, what do we know about gram-positive organisms? Thick layer. Good job, Ashley. Yes, they have a thicker layer than your gram-negative organisms. That is correct. Okay, it's spore forming. It's an anaerobic bacillus. So anaerobic, what is that? All right, it does not need oxygen. It grows in the absence of oxygen. Very good. And it produces 2 large toxins, primarily A and B, and toxin A is an enterotoxin and cytotoxin. Toxin B is a cytotoxin, and then you have this binary toxin, which has been found in about 5% of C. difficile isolates and in 100% of this specific epidemic strain of C. diff, and it causes diarrhea and colitis in susceptible patients, right? I know this is kind of a lot of information that we're familiar with. And so basically people that are in high risk environments, which include acute care hospitals, include long-term care facilities in which the use of antimicrobials is high, that increases a person's risk of acquiring Clostridium difficile. Okay, and so an epidemic strain of C. diff, which is the one that we're dealing with down here, the NAP 10227, It produces high levels of toxins A and B, and they also possess that third binary toxin, which is highly resistant to fluoroquinolones, antibiotics, and has spread widely throughout North America and Europe with associated high mortality and morbidity. So, Clostridium difficile is an urgent threat and it's a public health threat. This comes from the document that was published on antimicrobial resistance in organisms of public health importance by the CDC in 2013. And so we'll just kind of go ahead and go through some of these main bullet points. So C. diff causes a life-threatening diarrhea, and these infections mostly occur in people who have had recent medical care and antibiotics. So once again, they're in those high, risk environments. So although resistance to the antibiotics used to treat C. diff infections are not necessarily a problem, the bacteria spread rapidly because it is naturally resistant to many drugs used to treat other infections. In 2000, a stronger strain of the bacteria emerged. This strain is resistant to fluoroquinolones, antibiotics, which are commonly used to treat other infections. This strain has spread throughout North America and Europe, infecting and killing more people wherever it spreads. So about 250,000 infections occur per year requiring hospitalization, or they are affecting people who are already hospitalized. There are 14,000 deaths per year and at least 1 billion in excess medical costs per year. That's related to C. diff have increased 400% between 2000 and 2007, in part because of a stronger bacteria strain that emerged, and that's the one that we previously saw on the slide, which is in North America and Europe. And almost half of infections occur in people younger than 65, but more than 90% of deaths occur in people 65 and older. About half of C. diff infections um, first show symptoms in hospitalized or recently hospitalized patients, and half first show symptoms in nursing home patients or in people recently cared for in doctors' offices or clinics. So this is kind of the lowdown on C. diff, right? Gram-positive organism, anaerobic. All right, so question 1. Which factor is commonly associated with Clostridium difficile infections? A, chemotherapeutic agents, B, ACE inhibitors, C, prophylactic antibiotics or antibiotic used to treat a primary bacterial infection, and D, antiviral medication to treat a primary viral infection. Okay, we have a lot of C's. We have one B. Okay, the majority of you are all putting C's, which is correct. Prophylactic antibiotics or antibiotics to treat a primary bacterial infection. And that goes back into basically people being in these high risk environments, being exposed to antibiotics which alters their microflora in their stomachs, in their gastrointestinal system, which can really throw things out of whack for people. All right, question 2. What is or are the highest risk antimicrobials associated with causing Clostridium difficile infection? A, third generation cephalosporins, B, fluoroquinolones, C, clindamycin and vancomycin, and D, metronidazole. Okay, oh, this one's pretty diverse. We have a lot of A's, some B's, some C's, so we do have some diversity in these answer choices. Okay. All right. So the highest risk antimicrobials associated with causing CDI are going to be your third generation cephalosporins. And this is coming directly from the text. So third generation cephalosporins have supplanted clindamycin as the highest risk antimicrobials associated with Clostridium difficile infection. Now, what class of antibiotics do cephalosporins belong to? Fluoroquinolones, beta-lactams, macrolides, aminoglycosides. Okay. Yeah, we have a couple people putting beta-lactams in here. All right. Very good. They are beta-lactam drugs. And then why are the remaining answers incorrect for our previous? Well, fluoroquinolone, resistance to fluoroquinolones it's an emerging trend for Clostridium difficile infection. And then you utilize clindamycin, vancomycin, and metronidazole as treatment options for Clostridium difficile. Okay, so now we have CDI detectives. So this is where we're going to have scenarios dealing with C. diff. This is how we're going to do it, okay? So our first scenario, I'll go ahead and go through it. A 67-year-old female with a past medical history of congestive heart failure, coronary artery disease, and IBS presents to your ED with symptoms of abdominal cramping and profuse watery diarrhea. She reports having had 10 episodes of watery diarrhea in the past 24 hours. The patient states that she's on vacation and visiting from Western Europe. The patient also reports recent hospitalization in Western Europe with antimicrobial treatment. What are your concerns with this scenario so far? Some of you saying antibiotic treatment. Okay, what else? Most of you are saying recent antibiotic treatment, hospitalization, that she's abroad. All right, these are all good things that you guys are bringing up. Very good. Age, okay. So age is a concern. Yeah, we know age is a concern. All right, exposure to C. diff via hospitalization in Europe, history of IBS. Okay, wonderful. Those are all very good points that you should be thinking about. So our thought process is, number one, does she meet CDI criteria? So diarrhea is the most common clinical symptom of CDI, and the description is going to be soft, unformed stools to watery or mucoid, in consistency, 3 to 20 bowel movements per day. 22% of patients experience abdominal pain and cramping, and 28% experience fever. The presence of 3 or more unformed watery stools in a 24-hour period in a hospitalized patient is sufficient indication to submit a specimen for C. difficile testing. Another concern is travel history. So the patient is originally from Western Europe, and she was recently hospitalized. And a lot of you did state that this is an issue because she has been, to another part of the world, and she does have a lot of health issues. That also puts you at an increased risk for complications, right? We read that in the chapter. Okay, so the Bristol stool chart. We need to be familiar with this chart. It is a beautiful chart which really gives you detailed drawings of what is an acceptable specimen to submit to the lab. So at types 1 through 7, which type is acceptable to submit to the lab? I just need a number. For C. diff testing. Okay. We have some 4s. We have a lot of 7s. Okay, so for C. diff testing, you're going to want to make sure that the stool specimen that you're submitting is completely watery and conforms to the shape of the container. So it needs to be able to conform or basically fit into whatever shaped container you put it in, right? You don't just want to be sending, type 1 to the lab when you're concerned for C. diff. So our scenario continues. As a medical provider, you decide to order a stool culture and PCR testing for suspected C. diff infection. The patient's laboratory results shows the following. They have a white blood cell count of 25,000, a positive occult fecal blood test. And what does an occult fecal blood test look for when you order that? What are you Oh, Angela, so fast. Very good. Blood in the stool. I love it. Yes. So the patient has been in your ED for about 3 hours, and now she's developed a temperature of 101.3. You're currently patiently awaiting CT results, and this is us over here, patiently awaiting CT results, because they always tell you that your patient is next in line, even though they never really are. Because CT, they stay lying to us. And so it's important to note over here with these lab results that about 50% of patients will develop leukocytosis and 26% of patients have an occult fecal blood, right? When it comes pertaining to C. diff. So I have a pop quiz question here. So what is considered the gold standard for CDI diagnostic testing? A is stool culture, B, cell cytotoxic assay, C, an enzyme immunoassay for toxins A and B, and D, PCR. And this is what you would consider your gold standard. Oh, I have every answer up on the board right now, A through D. Okay. It seems that C is winning. Have a lot of C's. Okay. So the gold standard for CDI diagnosis is going to be culture. Culture is the most sensitive test of stool available, but has some false positive results due to the presence of non-toxigenic C. difficile isolates. It is generally considered the gold standard for CDI diagnostic test because of its sensitivity, but the turnaround time of 7 days prevents it from really being employed in the clinical setting. So even though it is the gold standard, you're not really going to see it being utilized as much in a clinical setting because of how long it takes for you to get those results. So now that we know that culture is the gold standard, what has become the predominant method of diagnostic testing utilized for identification of Clostridium difficile? Chris says PCR, 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 lots of PCR. Okay. Yes. Okay, so nucleic acid amplification tests have become the predominant diagnostic test for CDI diagnosis in the United States, which has impacted reported rates due to increased sensitivity and increased awareness of asymptomatic colonization with C. difficile. So you guys are correct. Now let's look at some of our most common complications of C. diff. So what do I see right here, this very first picture up on the screen? What are we looking at? Very good, Angela. Pseudomembranous colitis. Yes. So that's what we're looking at here. Over here, we're looking at toxic megacolon, perforation of the colon, right? When the colon is perforated, and then you have some fecal soilage in the abdominal cavity that is not fun for anyone. And then an ileus. I didn't have enough room in my slide, but an ileus is a painful obstruction of the ileum or other part of the intestine. So these are the complications that we're really afraid of when it comes to C. diff, because they can tend to have some pretty bad outcomes for your patients, right? So this is important for you to keep in mind. And I always like to include pictures because some of us are visual learners, and it's going to be a lot easier for us to remember some of these pictures, right? And so for the toxic megacolon, this is going to be an acute form of colonic distension, and it's characterized by a very dilated colon accompanied by abdominal distension and sometimes fever, abdominal pain, or shock. And as far as the ileus, if you guys want to have that visual picture, just Google it and some good images will come up. I just didn't have enough room in my slide. So we're continuing with our 67-year-old female. So you've gotten your CT results and it shows a dilated colon. Laboratory results have also identified that your patient has the BINAP 027 strain of C. diff. So what are your immediate concerns once you have these results? What are you worried about when it comes to your patient? My IPs are saying isolation right away. Obstruction, okay. Put them on contact precautions, transmission to other patients via healthcare personnel, right? Well, we would hope that initially, right? So typically what occurs is when you send off um, a sample to the lab, right? Because you're concerned for C. diff, the person will automatically or should automatically go on contact precautions since this is part of your differential, right? This is part of what you think this person might have. And so as a precautionary measure, you'll have them placed on isolation. But this is more relating to, to what's going on with specifically this patient's health. Oh, Cheryl reporting to the health department. Very good, Cheryl. Yes, keep us in mind when you have any, any interesting cases. And so, yes, all of the things that you guys are saying are very important. But so specifically with this strain, it's really highly resistant against antimicrobials, and studies have shown that in outbreak situations, it has a 30-day attributable mortality rate of 6.9%. So this is a toxin variant strain that has become widespread in North America and Europe, and this strain of C. diff has caused outbreaks in hospitals in Canada, the United Kingdom, and Western Europe. And when these outbreaks occur, as you can see, they can be pretty bad for the people involved. Now, as far as treatment options, if you're suspecting that someone has C. diff, what is going to be one of the first things that you're going to want to consider doing for this patient? Right? So Vanco, Flagyl, more Vanco, okay? So a lot of antibiotics. So our first line of treatment is to discontinue the provoking antimicrobials if they are still in use. Very good, Amanda. Yes, discontinue provoking antibiotics and then vancomycin, right? And so then we have some additional treatment options. We can do metronidazole for 10 days. We can do oral vanco for 10 days. I apologize, I'm not a pharmacist, but I'll try my best. Fidaxomicin, I apologize. And then FMT, which is fecal microbiota transplantation. So this is what we're dealing with. This is the treatment recommendations for adults in your APIC text, right? So this is what they're recommending as far as treatment. And I know there's going to be a lot of different recommendations for treatment, but when you're preparing for this exam, it's really important that you're sticking as much as you can to the APIC text because this is where the information for your exam is coming from. So for an initial episode, mild to moderate, you're going to do oral vanco or this one right here. And then your alternatives would be metronidazole and if the options above are not available. If the initial episode is severe, you would do oral vancomycin or fidaxomicin. For a first reoccurrence, you would do oral vancomycin and consider prolonged or taper or fidaxomicin again. And then for a second reoccurrence, you have this whole regimen right down here. Okay. So give me just 1 second. All right. So for our person, she appears to be pretty sick with a pretty resistant antimicrobial stain. So we would antimicrobial resistant strain. So we would definitely want to consider quite possibly, FMT since that strain is very resistant to antimicrobials. Okay, so let's start with scenario 2. A 77-year-old male with a past medical history of diabetes, coronary artery disease, and chronic kidney disease has been in your med-surg unit for 3 weeks. The patient has had a sudden onset of diarrhea with 5 episodes in the past 12 hours. The patient notified his nurse. However, the attending physician did not receive notice of these symptoms. The patient continues to experience diarrhea for an additional 12 hours before the attending is made aware of his symptoms. At this time, the patient has not been on contact precautions for a total of 24 hours since symptom onset. What are your concerns in this scenario? Spread of bacteria, risk of further spread, transferring it. Does he have a roommate? Is he in a semi-private room? Um, Contamination to the environment and exposure to others. Age, risk of spread, making sure you're notifying the nurses. Okay, so these are all really good things. So with this issue, right, we see that the issue is we're considering that this patient has C. diff, but the scenario is focusing more around kind of the infection control, right? Because we're concerned that he's been off contact precautions for 24 hours since his symptom onset. So some infection control key questions you're going to want to know is the patient on antibiotics, right? Because if he's on antibiotics, that could be exacerbating the issue. We're going to want to discontinue those antibiotics. Does the patient have a roommate? Many of you put this in your as part of your answers, so that's very good that you're thinking if he has any roommates. And then potential risk of spread of disease due to lack of proper personal protective equipment utilization. And also if this person is not on if the person is not on special enteric precautions, right, which are very similar to contact precautions, except there is one difference. And what is the one difference between contact precautions and contact enteric precautions? Right. Washing your hands. Instead of the alcohol-based hand rub, you're going to want to make sure that you're washing your hands. Correct. So if this person has not been on the proper contact enteric precautions, then your healthcare providers have not had the opportunity to practice their best infection control, right? So we have a little bit of a miscommunication situation, right? So the infection preventionist is notified of the communication error that occurred in the med-surg unit, and she's instructed by leadership for the patient's room to be cleaned with a 1 to 10 hypochlorite solution and for all of the residents in the unit to be tested for C. diff. What should be her next steps? And remember, we really have to put our thinking caps on and we have to our best to think as an infection preventionist. And I know some of you are, right? Oh, Carrie, very good. She should tell leadership not to test all for C. diff as it is only for symptomatic patients, okay? You don't need, Terry Harder, she says you don't need to test all the residents in the unit, okay? Gina's recommending surveillance of the unit. We have some people saying to test the staff, monitor for symptoms. Okay, so we have a couple of different ideas kind of happening here. Amanda, okay, Amanda, very good, very good. Okay, I'm going to read what Amanda put, but I'm going to go on to the next slide. So Amanda said, assess the value of using the hypochlorite solution as it is not very effective and is a skin irritant, and promote hand washing. And so we have some questions here. Right, so the thing that I'm trying to get across here is that there's times when you're trying to do your job and you're trying to do what's right, and leadership might want to kind of jump the gun and be like, we need to handle this, we need to take care of this, let's clean the room with hypochlorite, let's test all these patients. And you as an infection preventionist need to be able, right, and this comes into the portion of your management and communication, which is one of the modules that we'll discuss later. You need to be able to clearly communicate why those may not be our best options, right? So show me the Carfax about this hypochlorite solution, right? So widespread environmental disinfection with hypochlorite solutions have not been evaluated for sufficient efficacy, right? And it has the potential for major drawbacks because of the odor, respiratory, and skin irritation and damage to surfaces that it can do. So you should immediately be thinking, when you read that previous recommendation, well, do we clean rooms with hypochlorite? What is the research behind that, right? Is this the best thing for us to do to reduce environmental contamination in our unit or in our hospital? And so one thing that I did here, and this is because you need to start from early on trying to find ways to memorize all these chemicals and kind of the issues or the side effects or the drawbacks that they may come with. And so with hypochlorite, we have the O here for odor, the C for cutaneous, and the R for respiratory, right? And so these are issues that can happen. They're drawbacks because they can cause a lot of irritation for your employees who are utilizing it. And then asymptomatic patients should not be tested for C. diff, right? Because you have a lot of patients that are exposed to C. diff in healthcare facilities and they're just carrying it and they're not symptomatic. It's not causing any issues. So if you go testing for it and then you try to treat, you can cause a lot of issues, right? Okay, so Management of C. difficile and fecal microbial transplant by Dr. Christine Kruger. This is an absolutely fantastic lecture. I've listened to it about 3 times, once when I was preparing for my exam, once for cohort 1, and then once again. I listened to it this week, actually on Wednesday evening. Prior to having this meeting. And so she does a fantastic job of explaining everything in a more, she's able to kind of dive more in depth with C. diff because that's kind of her area. That's what she does. And so if you have time, I know I give you guys a lot of additional resources on YouTube or other places for you to watch some lectures. And the issue is that you need to be able to have a very clear understanding of these key chapters for your exam. So some of us, it's very easy to read a chapter and remember everything that we read, but for others, it's not that easy. You read a chapter and you forget half of what you read, or it's not very clearly like delineated in your brain. You're not able to pick facts apart and be able to apply them you know and so that's why I always recommend lectures, because it's an audio visual experience, and she has a lot of really great pictures that she's able to explain and that she goes into detail about. And so she has some case studies in her presentation, so if you do have time this weekend or sometime next week to watch her lecture, I would really recommend it. Now, open biome is just a fecal, it's a microbiome or a fecal microbiome company that I wanted to tell you guys about because we didn't have a ton of time to talk about, FMT, fecal microbiota transplant, but it's very important for you guys to be familiar with this type of treatment. So this is a research institute, and they were founded by a team of doctors, scientists, and public health advocates, and they have 2 primary objectives. They aim to eliminate the practical barriers to fecal microbiota transplantation, and second, they seek to enable translational research into the human microbiome. So that's just for some additional information there. So let's ask some questions here. So true or false? 50% of infants through about 1 year of age harbor the organism and its toxin without any gastrointestinal tract symptoms. And this is relating to C. diff. We have some trues. We have 1 false, 2 false, 3 false. Okay, so we have mostly true. Yes, so that is correct. Now, the next one is 60% of hospitalized patients of all ages asymptomatically carry toxigenic and non-toxigenic strains of C. diff in their stool. Is that true or false? This is kind of half and half. I'm getting true, false, true, false. Okay, so we're kind of split. We're kind of split half and half. Okay, so this one's false. And this one was a little bit of a tricky one because it's actually 20%. 20% of hospitalized patients of all ages asymptomatically carry toxigenic and non-toxigenic strains of C. diff in their stool. And so that's where we come back to that scenario where, your leadership was telling you, we need to test everyone on the unit. And you need to be like, well, actually, ma'am, 20% of hospitalized patients of all ages asymptomatically carry toxigenic and non-toxigenic strains of C. diff in their stool. So there's a high, possibility that we're going to find it in our unit, right? And so I know sometimes you're thinking, why is she giving us all these weird little facts and these percentages? And it's just to increase your knowledge on these microbes, on these pathogens. All right, question 1. Which of the following treatments has been shown to significantly improve the prevention of recurrence of C. diff infection? A, fecal transplants, B, subtotal colectomy, C, colon cleansing, and D, antimicrobial therapy. Okay. You guys all got this one. A, yes, fecal transplants, correct. So, fecal microbiota transplant is a procedure in which fecal matter or stool is collected from a tested donor, mixed with a saline solution, strained, and placed in a patient by colonoscopy, endoscopy, sigmoidoscopy, or enema. It increasingly appears that fecal transplants are effective in treating recurrent CDI. Fecal transplants have been shown to be effective in treating stubborn cases of C. diff, with many physicians reporting success rates of 80% to 95%. In Dr. Kruger's lecture, she talks about different case studies of people who received FTM and others who did not. It's very interesting. She's such a wonderful presenter. Okay, so question 2. The IP provides an in-service to the ICU nurses on Clostridium difficile. Which of the following statements is true regarding bacterial spores and should be emphasized? A, they allow the bacteria to multiply in adverse conditions. B, they are resistant to antibiotics. C, they are usually formed by gram-negative bacteria. And D, they can be identified with gram stains. And I should have capitalized Graham in these answers. I apologize to you, Christian Hans Graham. Okay, let's see what our answers are here. Okay, so we have A, B, C, some more A's. Okay. Okay, I think it's in between A and B. Right? And so when we're looking at this question, I don't particularly love this question. I think it's a bit tricky and misleading, but it is coming from your certification study guide. So, they'll try to throw in some funky looking questions just like this one. And so when you're going through this, right, you can kind of start crossing off some of these answer choices. They can be identified with gram stains. I mean, that's not okay. Okay, wonderful. They can, but is this really something that should be emphasized during an in-service to your ICU nurses? Do you think your ICU nurses are going to go home and they're going to be like, "Well, did you know?" That's not necessarily what is important. And so you can kind of understand that your answer choices are either A or B. So they allow the bacteria to multiply in adverse conditions, or they are resistant to antibiotics. So the correct answer is that they are resistant to antibiotics, right? And I guess their thought process behind this answer is that if you have a spore in a not, in a condition where it's being threatened, they're not multiplying when they're in their spore form. They're being protected until that environment until they're able to multiply once again. And so I don't necessarily love this question. I think it's a bit misleading. When I first took my practice test, I got this one wrong because I didn't, I didn't fully, I understand what they're asking you, but I do think this is a little bit of a tricky question. And so you have to come at it from a different perspective. Right. Okay. Yes. And so Angela said that they don't multiply as a sport. They're really trying to get at what a sport is. Okay. Wonderful. Okay, so let's move on to question 3. A patient was recently diagnosed with C. difficile infection of the colon. You're called to institute contact precautions and do all of the following except. Which of these statements are true? A. Gloves and gowns required before entry. B. The patient is limited in movement outside of the room except when absolutely medically necessary. C. Move the patient to a single room. And D. The patient is moved to a negative pressure room to avoid airborne fomite exposure. Very good. Yes. So this is an easy one. So D. Yes. You don't need to do all this. You're really doing the most, right? If you it's absolutely not indicated, it's not necessary, and this comes down to just ensuring that you're able. Angela said airborne fomite, is that a real thing? I didn't make this up. Okay, this is from the APIC text, so they do ask you these kinds of questions. But yeah, it's not necessary. You need to, they're making sure that you understand transmission. They're making sure that you're able to kind of go through the process and think, well, what is going to put other patients at risk, or that you actually know what, transmission-based precautions are. Okay, so now we're going to get into chapter 95, and it is 241, so let's try to move through this. All right, so we're talking about tuberculosis. So how many of you knew that George Orwell died of tuberculosis? Did any of you guys know that? All right, so I learned a lot about George Orwell this week. So his actual name was Eric Arthur Blair, right? And he wrote his last novel in 1984 at a friend's house in Scotland when he was actually really ill with TB. And so he talks about, there's a quote where he talks about what the collapse therapy was like. And so one of the writers for a column said that fever, weight loss, and night sweats sent him to the hospital where he underwent collapse therapy, a treatment designed to close the dangerous cavities that form in the chest of tuberculosis patients. Right? So this is a quote that he wrote. So the treatment they are giving me is to put the left lung out of action, apparently for about 6 months, which is supposed to give it a better chance to heal. They first crushed the phrenic nerve, which I gather is what makes the lung expand and contract, and then pumped air into it, actually under the diaphragm, which I understand is to push the lung into a different position. I have to get refills of air in the diaphragm every few days, but later it gets down to once a week or less. And once again, that type of therapy was used to close tuberculous cavities. And cavity formation is the most ominous event in the pathogenesis of tuberculosis, right? And so it was really interesting to kind of learn about this. In the article, which I linked down here, they talk about how, as his disease progressed, while he was writing 1984, he became cachectic, and that's you know that's just so sad. He lost a lot of weight. He was very sick. But yeah, so this is kind of our history fact for the day. And he did actually expire from tuberculosis once he finished his book. All right, so let's talk a little bit about the background of TB. So the highest incidence rates of active tuberculosis occur in Africa, about 363 cases per 100,000, and Asia, 180 cases per 100,000. The TB rates rose in the United States from 9.3 cases per 100,000 in 1985 to 10.5 cases per 100,000 in 1992. Why do we think those rates increased between 1985 and 1992? What was happening at that time as well in the United States? Terry, very well, HIV epidemic. Yes, good job, Elizabeth. Oh, I see some of you did your chapter readings. Very good, very good. Yes, so HIV, right? This is when we started seeing HIV in the United States, the early rise, right? 1980s. Okay, by 1994, 20 healthcare personnel had acquired multi-drug resistant tuberculosis and 45% of those had died. So this is just a little bit into what that history was like initially with TB. In 2011, the TB rate was significantly lower, right? We went from that 10.5 in 1992 to 3.4 in 2011. So why? How are we able to lower those rates? So it's a variety of things. So implementation of expanded treatment regimens, increasing coverage of direct observed therapy. And what is DOT? What is direct observed therapy? Yes, you're watching the patient actually take the medication. You're making sure that people are taking their medication because some of these medications have some really awful side effects and people sometimes don't want to take them. They don't want to be compliant with their treatment, right? It's not a pleasant disease to deal with. The drugs are not very, they're not very good for the patient. And so a lot of people, they start out with their drugs and then once they feel a bit better, they don't want to keep taking them. And as we know, tuberculosis treatment is for quite some time, right? Okay, so we have increasing coverage of DOT, including involuntary detention and administration of therapy when needed, and implementation of CDC recommended infection control recommendations. Now, in 2011, there were 6 extensively drug-resistant TB cases, right? Defined as XDR-TB, defined as TB resistant INH, rifampin, any fluoroquinolone, and at least one of the injectable second-line drugs, amikacin, kanamycin, or capromycin. So we know that extremely drug-resistant tuberculosis is an issue. So tuberculosis and other mycobacteria. Tuberculosis is a causative agent for tuberculosis. It's an aerobic acid-fast bacillus, right? So it likes oxygen. That's why it starts sometimes in the bottom part of the lung, and then once it's, if it's reactivated, your immune system goes down, it'll start to move up towards the upper lobes, which have a lot more oxygen, right? So it's an aerobic acid-fast bacillus. People are infected with tuberculosis primarily via inhalation, right? It's airborne. That's why we're going to put our patients in what type of pressure room? Negative pressure. Very good. Multi-drug resistant tuberculosis and extensively drug resistant tuberculosis strains have emerged in recent years and are more difficult to treat. Non-tuberculous mycobacteria can cause a variety of diseases, including pulmonary, skin, and soft tissue infections, especially in immunocompromised individuals. Can you guys tell me any other organisms or other mycobacteria, the name of other mycobacteria besides your tuberculosis? Mycobacterium abscessus, Mycobacterium avium. Okay, we have 2. Very good. All right. Mycobacterium bovis. Good, good, good. Very good. Lots of fun names. Did I miss anything on this other slide? Let's see. No, I'm good. Okay. So this is our acid-fast stain, the Seal-Nielsen stain. And so remember, we went over this, I think 2 weeks ago, the acid-fast stain, how you need to apply heat in order for that stain to actually bind to this microbe. So Mycobacterium tuberculosis is an aerobic, poorly staining gram-positive bacillus. Like other mycobacteria, it is acid-fast, meaning that certain stains, such as quinine or Seal-Nielsen, will not decolorize with acid alcohol. And this is a little bit of an example. I haven't done an acid-fast stain, so I've never actually seen one under the microscope. But so I can't really compare. I'm not sure, but this is one of the images that I found. And that's just because I feel images help people remember information. All right, so tuberculosis spread. Right, so when produced indoors, like a hospital room, these particles may be suspended in the air for prolonged periods of time and travel through the ventilation system of the building to infect susceptible individuals located in other areas. That's why we got to put our patients in negative pressure rooms. We got to do airborne isolation. We got to make sure our staff are utilizing the proper personal protective equipment before they're going into these rooms. Now, prevention of TB. So, prevention of tuberculosis is based on detection of cases, airborne isolation in appropriate negative pressure rooms, respiratory etiquette, use of an N95 respirator, and early and complete treatment of tuberculosis cases based on susceptibility testing. Okay, in a negative pressure room, and I don't know the answer to this, but I will know the answer next week. Um, what type of air, are there any type, is there a number of air exchanges that need to occur? This is for my more experienced IPs that may be on the line that deal with this a lot more. Oh, here we go. Okay. Cheryl from Florida Hospitals telling us at least 12. Very good. Yes. So I haven't reviewed my isolation rooms and the specific air exchanges, but this is something that you will be tested on. That's why I'm asking right away. And you guys have to realize that, you know, I am not an IP, right? So there are going to be times when there's information that I may not have readily available. And it's okay. It's okay for us to not know everything, but this is why we're in a group and this is why we have a lot of different disciplines in here so that we're able to help each other learn and so that when I have a question, I have beautiful people who are intelligent and can help me, right? Collaboration, not competition, is the key to our success, people. Okay, so we have a scenario. So Samuel is a healthy 45-year-old male with no significant past medical history. He recently visited Africa with his wife on a 1-week vacation. He starts his new job as a nurse in an LTAC 2 days after returning from his trip. Samuel completed his PPD test upon hire, which was negative. As the employee health nurse, do you have any concerns with this result? Okay, we have recent travel to Africa. Needs to step on higher. He's a healthcare personnel. Cheryl says, no, not too concerned. Okay, so depends on the timing. Was the result before or after the trip? Depends on where in Africa. When did he do his test? Oh my goodness, guys. Okay, I was not ready, right? Okay, so the main point here, right, is that there's a minimum or there's an average amount of time that it's going to take for that PPD to be positive. So you are exposed to tuberculosis, right? Let's say Samuel, unfortunately, that he was exposed to TB while he was in Africa, right? Since we do know that they have higher rates of TB in Africa. It's going to take about 1 to 12 weeks in order for that test to actually come up positive, right? 8 to 10 weeks after exposure, Elizabeth says. So, and that's because of how long it takes for your body to be able to recognize the mycobacterium. And that comes into that pathophysiology chapter. I mean, paragraph in chapter 95, you know, the pathophysiology chapter where they go through from the time that you're exposed, how long it takes in order for it to travel to the alveoli, to be inside the macrophage, to replicate, and then for you to develop an immune response or a specific immunity. That is where this question or where this point is coming from, because this is information that you need to make sure that you know, right? So yes, you should be a little bit concerned and you should be planning to conduct a follow-up test. All right. Question 1, the optimal time to collect a sputum specimen for an acid-fast bacilli testing to rule out TB would be first thing in the morning, after respiratory treatment, prior to the patient going to bed, and prior to a respiratory treatment. All right, you guys all know this one. Danielle Walden said A with like 6 exclamation points. Yes, first thing in the morning. You're gonna want to make sure that you get this done first thing in the morning. Question 2. When a patient with AIDS is admitted with possible pneumonia, the physician, who is a general practitioner, orders airborne isolation. What is the correct response? A TST skin test should be placed to determine if patient may have TB. B, a sputum specimen should be collected for acid-fast bacilli daily times 3 if TB is suspected. C, if the chest radiograph is clear, isolation can be discontinued. D, PCP is not transmitted person to person and does not require isolation. Let's see what we have here. Okay, so we're stuck between a couple of different answers. A, B, B or D, some D's. Right. So what is answer D down here referring to? PCP. What's the name for this? This is an abbreviation, right? And this is out of the APIC test. Pneumocystis carinii pneumonia. Very good. Very good. Pneumocystis carinii pneumonia, right? Which we now really just say pneumocystis jirovecii, right? And so that's what that's referring to. And so the the thought behind this one is that people with HIV are at high risk for developing TB. So if TB is suspected, you're going to want to make sure that the patient is placed in airborne isolation and that a sputum specimen for acid-fast bacilli should be collected daily times 3. Okay? And D, why would D be incorrect? Why would we, okay, you're assuming AIDS diagnosis is caused by PCP because it needs droplet precaution still. You do not have a diagnosis, you're just assuming. Very good, right? At this point, they're admitted with a possible pneumonia. You're not exactly sure what it could be. It could be TB, it could be PCP. You're not sure. So you need to take the necessary isolation precautions. All right. Now, this is a question about influenza, where we're jumping into flu. Flu was one of the chapters you were supposed to have read. So, which of the following statements is false regarding influenza viruses? A, they are divided into 3 categories, A, B, and C. B, influenza A strains have been the predominant cause of worldwide epidemics. C, influenza A and B strains have been named according to the city or state and year of their initial isolation. And D, influenza B strains have not been associated with large epidemics. Which of the following statements is false regarding influenza viruses? Okay. So the statement that is false is influenza B strains have not been associated with large epidemics. Okay, my question's a little bit out of order here, so I apologize. A patient with rust-colored sputum, malaise, weight loss, and fatigue is admitted to the medical center from a long-term care facility. The doctor orders sputums for acid-fast bacilli smear and culture fungal and bacterial cultures. A chest radiograph shows right upper lobe infiltrates. The patient has a negative PPD and one sputum specimen smear is negative. A, isolation should continue. B, isolation can be discontinued after the second sputum smear is negative. C, the patient can be removed from isolation because he does not have TB. D, isolation can be discontinued after he has been on antibiotics for 24 hours. We have some A's. We have some B's. Okay. So the correct answer is A, isolation should continue. For patients placed under airborne precautions because of suspected infectious TB disease of the lungs, airway, or larynx, airborne precautions can be discontinued when infectious TB disease is considered unlikely and either A, another diagnosis is made that explains the clinical syndrome, or the patient produces three, not two, 3 consecutive negative sputum smears collected in 8 to 24-hour intervals, right? So 3 consecutive negative sputums. All right. The validity of a culture report is dependent on the quality of the specimen sent. To determine if an expectorated specimen was sputum and not saliva, the gram stain should show A. More than 10 epithelial cells per low power field in abundant Pseudomonas aeruginosa in pure culture. B. More than 10 epithelial cells per low power field in moderate to abundant polys. C. Many white blood cells in organisms on low power field. And D. Fewer than 10 epithelial cells per low power field. And this is you're trying to determine, right? You're trying to determine if basically this is a good sample. You want to make sure, hey, that I'm testing the right thing. So we have a lot of D's. Very good. Fewer than 10 epithelial cells. So sputum cultures rely heavily on good sample collection. So if an examination of a gram stain, you're seeing a significant number of squamous epithelial cells, the ones that, they line the mouth, then the sample is not generally considered adequate for culture, and a recollection of the sample needs to be done, okay? If the sample contains a majority of white blood cells, neutrophils that indicate a body's response to an infection, that is considered to be an adequate sample for culturing. All right, so let's quickly do our group member spotlight. So we have Ashley Joseph, and she has 2 dogs, Gus and Abby. This is Abby here in her picture. She loves 2 of her hobbies are powerlifting and strength training. She studied the history of ancient medicine in Greece and Rome as an undergrad at FSU and completed her thesis dissertation on how wounds, war, and weaponry led to surgical tool advancements in the 1st and 2nd century BC Roman military. So that's intense. I'm sure she could definitely have a really good conversation about that. And then one of her favorite hobbies is gardening, and she's a true believer in food sustainability. So I have 3 dogs, and I'm able to take care of them very well, but I have never been able to keep a plant alive. Every plant I've ever had has died, even the bamboo plant that was a gift. So that's definitely a skill, Ashley, and thank you so much for sharing with us. Okay, so I did put this PowerPoint together while I was at the conference, so I was unable to do my little last assignments. So for week 4, right? These are the last things that we need to read for week 4. And then we're ready to take our first um, 50 question practice questions from the certification study guide. So you're going to want to do Enterobacteriaceae, Legionella, diarrheal diseases, chapter 97, which is viral hepatitis. If you are an epi and you have a lot of really good experience with your enterics and you feel like you know those very well, I would recommend that you maybe focus on the questions that you missed on that practice 1 exam and pick some additional chapters to read or to go over. You want to make sure that you're tailoring your study process. We all have things that we're good at and things that and subjects that we lack in. I'm not very good at math, right? I'm stronger in my reading. So when I was preparing for the GRE, I knew that something I needed to improve upon was my math, right? And so for this CIC exam, when you're taking your practice questions and you're doing your practice exams, really understand what chapters are you missing questions from, what sections, what concepts, and go back and understand them. There's a lot of repetition in this exam. Yes, there's an incredible amount of information that you need to know, but be smart about your studying. So if you know, hey, I know these diarrheal diseases pretty well, that's a significant amount of pages. So if you can try to find ways to improve your toolbox so that you're better prepared for this exam, then do so. We're going to focus on Enterobacteriaceae, Legionella, and viral hepatitis next week. As you guys are starting to realize, it's really difficult to put all of the details from every chapter into our presentations because then our group meetings would need to be like 600 hours long, right? So that's why it's so important for you to make sure that you're reading prior to coming in to our sessions so that you're able to gain more from the sessions because you already have that knowledge from reading the chapters. So week 4, we have our assignments here. Just go to your CIC study plan. And if you have any questions, let me know. Otherwise, when will you be required to submit the practice exam? That will be next week. So once we're done with week 4, which will be next Friday, you'll have the weekend up till Wednesday to get those practice questions submitted in. Okay? I'm still waiting for one practice, one exam, just one. So once I get that, I'll be able to talk to you guys about what some of our weak areas are. But just know I haven't forgotten about that. Okay, guys? Thank you so much for, No, it's not Sebastian, Danielle. So, thank you so much, guys, for being here this Friday. Y'all have a wonderful weekend, and I'll see you guys next week to talk about some gram-negative organisms. All right? Okay, bye, everyone.